So let me welcome all of you. This is our honorary Greenfield lecture, which is an honor to invite a distinguished person from wherever to join us and to educate us about topics that are highly relevant to psychiatry and especially relevant to humanism in relation to psychiatry. We're thrilled that Dr. Ruth Shim is with us, and I'll give a little bit more of an introduction in a moment, but wanted to say a few words about why we call this the Greenfield Lecture and why that's important to the Department of Psychiatry. And I should say, for those of you that you are on virtually, I'm Dr. Kalin, Ned Kalin. I'm the chair of the Psychiatry Department, and also want to welcome all of you. This is our first hybrid experience. And so we've got folks in the audience, as you can see, and we've also got virtual folks on video watching. So if you can go to the next slide, please. So this is a picture of Dr. Greenfield. And the reason that we have this lecture is that he was a founder of the department and is somebody that really made a huge impact on the early years of the department, as well as the current years of the department. And to put it in a nutshell, his approach, he was a psychologist. His approach was extremely humanistic, and it really combined ideas about psychotherapy and psychosocial issues with, at that time, actually in the late 50s, early 60s, with what we knew about the body and what we knew about the brain. And Dr. Greenfield was visionary from the standpoint of his capacities to think about the science related to psychiatry and mental health. In fact, he was one of the first people that got into electrophysiology to try to understand the bodily manifestations of emotions and of psychological states. Very interested in mind-body connection, which continues to be a theme with us in our department today. He was also beloved by residents. He was a mentor to many, many people, and also had a very sharp mind from the standpoint of being scientific, but also had a very soft heart from the standpoint of being very empathic. And I think it was that really unique combination of sort of being hard-minded about science, but also being very empathic and very interested in emotions that brought together this combination of sort of an integrated approach to patients from the standpoint of what they were doing, where they were living, what they were experiencing, what their brains were doing, what their bodies were doing. But most importantly, as a psychologist, he really promoted psychotherapy in our department. And also our department grew up to be a very sort of egalitarian department from the standpoint of psychology and psychiatry. And to this day, one of the things that distinguishes our department, I believe, is the combination of, again, not only psychosocial, but and also pharmacological approaches with the patient, but also really an integrative approach across disciplines and psychologists and psychiatrists and scientists actually working hand in hand together. But again, I'll just come back to the most critical part of what he gave to the department and what we've maintained over time has been this humanistic approach. And it's one of the things that I highly value in our department, and we're always working towards trying to improve upon. And that really brings me to the introduction for Dr. Shim. There couldn't be a better person today to come here to talk to us about some of the next steps that we are thinking about and need to do in our department, I think in the medical school, and also frankly at the university. And Dr. Shim is currently on the faculty at the University of California, Davis. You can take a look at her bio here. She's an endowed professor in the area of diversity and inclusiveness in relation to education. She's, I'm sorry, she's an associate dean in relation to that, and an endowed professor in relation to clinic, help me out here. Thank you, cultural psychiatry. So she's positioned at the University of California, Davis in a role to really promote and develop programs related to diversity and things like that. She's clearly seen as a distinguished person in the field from the standpoint of her work related to anti-racism, the history of anti-racism, the impacts of racism, the impacts of racism on mental health and in psychiatry. And she's been quite outspoken about that in a way that has been extremely helpful for myself as a colleague and for other members of the field and for the field in general. one of the motivations for us to bring her here today was not just to give talks, she'll give one today and also one in the department tomorrow, but also to consult to our department to help us move forward with our commitment to be a better place from the standpoint of diversity and equity, and to be a better place from the standpoint of examining our potential attitudes that have become, have become racist, I suppose, in ways that were unintended. And so part of that is having her here to help us with that, and also thinking about how we can make positive changes in directions of diversity and equity. Her work has been well published in many, many journals. She's on the editorial board of a number of journals, including what used to be the Archives of Psychiatry, which is now JAMA Psychiatry. She has been very helpful to me in my role as the editor of the American Journal of Psychiatry, and has written 2 pieces for us, which I would encourage you to take a look at, especially the one on the effects of racism in mental health and in psychiatry, but also a really nice piece also collaboratively on related to thinking about how departments of psychiatry need to have DEI folks related to really digging in and being held accountable for and helping with initiatives like the ones that we're talking about in our department. So it's a great pleasure to have you with us, Ruth, and we really appreciate you during COVID coming out here and traveling across the country to be with us. And why don't you come up here and let's give her a round of applause and listen to her talk. There we go.
Okay, I'm going to take my mask off, but only because I'm at a safe distance from everyone. I thank you so much, Dr. Kalin, for that introduction. And I'm just so pleased to be here in person with all of you. I have a lot to talk about on this topic, and not the greatest amount of time. So I really wanted to launch right in, because I think that the work that we do here today is much of it's going to be in the discussion. And so I want us to get to that. Okay, so when we talk about these issues, I have to tell people before I launch into any conversation as it relates to talking about racism, I have to give a disclaimer. So I don't have anything to disclose, but I have much to disclaim. And so I'll get started. And what we first need to understand is that this is a very difficult and uncomfortable topic. It's difficult to talk about these topics as it relates to racism. And when we start to talk about these topics, a lot of times many complex feelings can emerge, and they include things like guilt, anger, resentment, defensiveness, and some of the things that happen when we start to have this dialogue is that you may actually perceive me of accusing you of being a number of terrible things, including racist and sexist and any other number of things. And you also may feel that perhaps as I'm talking about these things, that I have some sort of specific political agenda that I'm trying to advance. You may feel that I lack objectivity. All of these are emotions that may come up in the course of our discussions around these topics. The reason why I'm giving this disclaimer is because these have all been things that have been raised to me in the past when I have talked about these topics. So I want you to know they're normal feelings that people have when we engage with this material. I will just say that we all, because we all feel these things, I think it's very important, and the task that we have before us is when these emotions start to come up, when we start to feel these complex emotions arise within us, it is a really important moment to stop and practice self-reflection. It's a moment to say, why am I feeling this way right now? And if we can't acknowledge that we have these difficult emotions because of the ways that we're socialized in our society, it's very difficult for us to have the expectation that other people will be able to deal with these complex issues as well. So it's work that we have to do, even though it's hard and even though it's difficult. And today we're talking about social injustice, and we're talking about social injustice and mental health. And I have to say that, again, it's not easy to talk about these topics. So I'm still disclaiming. We have been socialized to believe that it's not polite to talk about racism or injustice or oppression. This starts when we're very young. We socialize our children. If they point out differences in people by race or by other things, we often say, oh, don't say those things. So we've been socialized that it's not appropriate to have these conversations. And then health professionals and mental health professionals in particular have not been taught about the connection between oppression, injustice, and health. There's a very clear line. And if you start to explore it, there's actually a very clear line between how oppression and injustice leads to poor health, but it's not something that we're traditionally thought about. And the other reason why it's so difficult to talk about social injustice is because we're in the midst right now of, with the death of George Floyd, what many people thought was a racial reckoning. We saw a huge shift happen for many people in terms of thinking about why it's so important to consider race and to consider trying to be anti-racist. The problem, of course, with that is that it's so difficult because we are now in the midst of something that many people saw was a racial reckoning. And now it's not so much a racial reckoning. And what I mean by that is that this is a chart that shows that white people in the United States are less supportive of Black Lives Matter than they were at the beginning of 2020, sorry. So prior to George Floyd's death, white people were actually more supportive with the Black Lives Matter movement. And then after his death, we saw a huge spike in support. And now, in 2021, we see that white people are even less supportive of Black Lives Matter than even before his death. So there is something about when we try to talk about these topics that it becomes challenging and difficult. And there's some sort of retrenchment that tends to happen. And we'll talk a little bit more about that. So the last part of my disclaimer is just some balm from James Baldwin to help as we're thinking about these topics and as these emotions arise in us. And James Baldwin said, I'm not interested in anybody's guilt. Guilt is a luxury that we can no longer afford. I know you didn't do it and I didn't do it either, but I am responsible for it because I am a man and a citizen of this country, and you are responsible for it for the very same reason. So with that, I think we can launch into our topic for today. So we are talking today about social justice and social injustice, and social justice is actually a complicated topic. It again has political connotations. We again think of negative political associations when we talk about it. Here is an article, an op-ed that was published in the Wall Street Journal by a physician by the name of Stanley Goldfarb, who was Associate Dean of the Medical Education Curriculum at the University of Pennsylvania. And he was lamenting about what he saw as a disappointing trend of medical school education focusing more on social justice topics and less on clinical issues. And one of the things he said in this article is, why have medical schools become a target for inculcating social policy when the stated purpose of medical education since Hippocrates has been to develop individuals who know how to cure patients? Curricula will increasingly focus on climate change, social inequities, gun violence, bias, and other progressive causes only tangentially related to treating illness, and so will many of your doctors in coming years. And this is an opinion that's held by a lot of people. This idea is if we spend time focusing on these political issues, we will miss the boat in terms of how to educate our medical students, how to educate our residents, and we won't focus on curing illness or fixing disease. And I just want to point out that is definitely one opinion, but he had his dissenters and detractors, including several physicians that work at the University of Pennsylvania, who published a corresponding op-ed in the Philadelphia Inquirer. They wrote that social and health policies have always determined who gets sick and who gets care and where and how. Understanding the social drivers of health and illness is not peripheral or tangential to health. It is the key to diagnosing and meeting a patient's fundamental needs. So it is a controversial topic. There are debates about this. There are two sides or even more sides to whether we should be thinking about social justice. And I think so because it's such a controversial topic, we need to really unpack it and define some terms. So social justice in and of itself is in fact a philosophical term. So one of the philosophers that really helped to understand what the meaning of social justice is David Miller. He said, and this is paraphrasing him, that social justice is the distribution of good or advantages and bad or disadvantages in society, and more specifically, how these things should be distributed in society. So it's concerned with the ways that resources are allocated to people by social institutions. So how we decide who in our society is worthy of certain advantages and who in our society is less worthy, or who is worthy of disadvantage in our society. Adding to that definition is the philosopher John Rawls, who said that social justice is assuring the protection of equal access to liberties, rights, and opportunities, as well as taking care of the least advantaged members of society. I highlight this point about the least advantaged members of society because we're talking about social injustice as it relates to mental health. And when we think about the least advantaged members of society, oftentimes we find that's people with serious mental illness. And it's not accidental that these outcomes that we see for people with serious mental illness are as bad as they are. It's that through line of injustice, as we talked about it, injustice and oppression, and how that leads to these poor outcomes. So it becomes a critical social justice issue. So also we must talk a little bit about the connection between social justice and race. And so when we think about race, we have to understand a couple of things. There are a couple of ground rules we have to think about when talking about it. First, we have to understand that race is a social and political construct. And what that means, it took me many years of hearing that to really understand what was meant by that statement. So when we say that race is a social and political construct, we mean that the whole idea of race was constructed. And many scholars would say that it was created and designed specifically by the idea of racism, that racism led to the need to categorize people in some way so that one group of people could be oppressed against another people, that need to do that as a society created the concept of race, created the idea that we could put people into certain classifications and then and put people into categories that way. So it was constructed by social and political means in order to advance the principle of racism. And we also know that race cannot be accurately biologically or genetically categorized. And so what we mean by that is that I cannot draw somebody's blood and determine what their race is. I cannot run a genetic test on someone and determine what their race is. But yet, even though we know these things to be true, race is still considered to be a rough and imprecise culture proxy for a number of things like culture, genetics, and socioeconomic status. And we also use race to confirm a number of assumptions, prejudices, and biases that we have about our patients. So we tend to use race in a very, I think, almost lazy way when we think about it in medicine, because we use it as a proxy for many things, and we often don't talk about what those other things are that we're using it as a proxy for. And we also use it to confirm and build on our biases about populations. So this is, I think, a very powerful quote that I feel we need to just sit with for a while. And it says, African Americans have higher incarceration rates, higher unemployment, lower incomes, lower home and business ownership, less education, less healthcare, more disease, and lower life expectancy than whites. If you believe Blacks are naturally dumb, sick, criminal, you have your answer for these discrepancies. If, however, you resist using stereotypes to make sense of your world, institutional racism provides a very practical and very traceable explanation for the inferior societal position of African Americans. I want us to pause and think about and contemplate this quote because it's pretty straightforward. We know these things to be true. We know that African Americans have higher incarceration rates, higher employment, higher everything bad. And I don't think we have always stopped to really ask ourselves what is driving those differences. I think we unfortunately sometimes err on the side of thinking that there may be some sort of natural intrinsic difference in our populations that is leading to these differences in outcomes. And even our best intended selves sometimes lapse into thinking in these terms. So let's talk a little bit about kind of the historical underpinnings of how we got to this place. So we probably recognize this particular image. This is a famous painting, The Signers of the Declaration of Independence. And we all know the very famous lines from the Declaration that said that we hold these truths to be self-evident, that all men are created equal, that they are endowed by their creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. An incredible sentiment. I think none of us argue with that. And we all, I think, identify very strongly with these being some of the founding words that created this country. But what I think it's important to understand is that when these founding fathers gathered in this space and said that these words are the principles upon which our society will live on, I think they were very clear that they actually didn't mean that all men were created equal. First of all, I think they were specifically talking about men. But also they did not mean that everyone was created equal. And I think that that we're clear about how our society was constructed, that we can look and see this image and know that when they were talking about making sure that everybody had the right to life, liberty, and the pursuit of happiness, that they were talking about these people in the room. They were talking about the people that look like these people. And all of those people got those accomplishments and those rights and those liberties. And then everybody else in our society was put into different categories by which they did not get those same advantages and they did not get those same rights. And that was written into the founding of this country, that was written into the policies by which we have grown as a nation. And I think we have to acknowledge that because I feel we spend a lot of time thinking so strongly about how America is a meritocracy. If you work hard enough, you can accomplish anything, that these are these great values we have as a society. But we don't always acknowledge that those societal values that we believe in so prominently were really skewed from the very beginning to only benefit particular populations. Then about 80 years later, you saw the rise of a physician by the name of Samuel Cartwright. He had some ideas in which he connected certain diseases that he said were related to Black people and particularly to enslaved Black people. He created certain disease categories that he associated with this particular population. One of those was something he called drapetomania. He said that this particular condition was the mental illness of a slave that was of a slave wanting to escape captivity. And so, you know, we can look at this now and say that was so ridiculous, but in the time with that context, this was considered to be a mental illness, that the idea that somebody would want to escape captivity, there would be something wrong with them. And what he said in speaking about that, he said, if any one or more of them at any time are inclined to raise their heads at a level with their master or overseer, humanity and their own good requires that they should be punished until they fall into that submissive state which was intended for them to occupy. They have only to be kept in that state and treated like children to prevent and cure them from running away. And another condition he described was something he called dysesthesia ethiopica. He said that this was a disease of rascality, or the general tendency of enslaved Black people to be lazy, to not want to work hard. And he said that this was just another mental illness that could somehow affect enslaved Black people. He said the disease is the natural offspring of Negro liberty, the liberty to be idle, to wallow in filth, to indulge in improper food and drinks. After the prescribed course of treatment, the slave will look grateful and thankful to the white man whose compulsory power has restored his sensation and dispelled the mist that clouded his intellect. So, you know, these things seem so extreme. And my point here is not to say that the origins of psychiatry were founded on the ideas of Cartwright. But I do want to point out how enduring the mindset can be, how this idea that there are certain populations that are naturally lazy, that don't want to work hard, how that has endured and has persisted over centuries, to the point that we look now at Black people and we sometimes think that certain Black people don't want to work hard, or certain Black people are lazy. And these ideas were codified hundreds of years before and have somehow persisted and have been sustained over time, and have somehow made their ways into the ways that we think about mental health and the ways that we assign certain behaviors and values to certain populations when we're thinking about mental illness. So I have to define a couple of concepts. The first is contrasting health disparities with health inequities. So health disparities are defined as differences in health status amongst distinct segments of the population, including differences that occur by race, gender, ethnicity, education or income, disability, or where you live. That is different from the concept of health inequities, which are disparities in health that are the result of systemic, avoidable, and unjust social and economic policies and practices that create barriers to opportunity. It's really important to contrast these things. But first, I think it's important to think about the idea that in the United States, we refer to differences in health as health disparities. Almost everywhere else in the world, when they talk about differences in health, they talk about health inequities. And again, I don't think it's accidental, but I just want to point it out. Is health disparities an incorrect term? No, it's not. It's a perfectly fine term. But what's different about it is that it says nothing about what the origin of the difference between health status is or where that comes from. Whereas health inequities is specifically saying that the origin of the health difference relates to systemic, avoidable, and unjust social and economic policies and practices. And again, health disparities is not incorrect, but if you do not designate where the difference is coming from, what is driving that difference, we have the tendency to err on the side of saying that that difference is seated somewhere in the individual or maybe in that particular group or population, and that maybe it's some sort of intrinsic difference, right? Maybe it's something biologically different about that population. Maybe it has something to do with the values of the people in that population. And maybe it has less to do with systemic, avoidable, and unjust social and economic policies and practices. We do this over and over and over again. When we talk about differences in health outcomes, we often err on the side of saying that it has something to do with the cultural values of that group. It has something to do with the personal choices that that group makes. And we spend less time thinking about what those systemic, avoidable, and unjust social and economic policies and practices are. And interestingly enough, those systemic and avoidable and unjust social and economic policies and practices are really the true drivers of why we see health differences of any kind, including mental health differences. So that gets us to talking about the social determinants of mental health. We define them as the societal, environmental, and economic conditions that impact and affect mental health outcomes across various populations. These conditions are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. And the social determinants of health are prominently responsible for both the health disparities and the health inequities that we see within and among populations. So I want to walk you all through my thought process on how I've gotten to thinking about these topics and how it relates to social injustice. So the book on the left is work that I did with Michael Compton, who co-edited The Social Determinants of Mental Health with me. Fred in the audience is someone who contributed to this book. And what we did with this book is that we really tried to gather all of the available evidence that showed social factors, those social determinants, and how they relate to mental health outcomes and poor mental health outcomes. And as we were doing that work, I started to understand that there was something that was really driving and pushing the social determinants of health. There were underlying causes to the social that created the social determinants. And I began to understand that it was actually the social injustice that was driving and really pushing the social determinants. And so I will walk you through that. And so this is work that I actually just finished with my co-editor, Sarah Vinson, in which we really put the concept of social injustice and laid out how that drives poor mental health outcomes. So I'll walk you through this figure because that really gets us to the point. At the very top, you see adverse mental health outcomes and mental health inequities. So the bad outcomes are at the very top, and each time you move down a level, you're actually moving further upstream. So one step down from adverse mental health outcomes and mental health inequities are a number of risk factors. In mental health, we spend a lot of time thinking about risk factors. The idea is, of course, that a risk factor precedes an illness or an event and increases the likelihood that somebody might develop that illness. And so in mental health, we say, let's intervene, let's find the risk factor, let's intervene so we can prevent the development of this particular illness or particular outcome. And so there are all of these risk factors. They include things like reduced options and poor choices and behavioral risk factors, physiologic stress responses, and psychological stress. And again, when thinking about the social determinants of mental health, I began to understand that if you're intervening at the level of the risk factor, you're often intervening too late because there's all this work that has set in long before the risk factor developed. And so we can use an example, for instance, of suicide risk assessments. We do lots of suicide risk assessments, but how many of the risk that we're calculating, how many of those things can we actually look at and intervene at that level when we're identifying that risk? Much of that is kind of set in stone and is in motion. There's very little that we can do to change many of those risk factors. And so we're really intervening too late. So the idea is we must go further upstream. And when we go further upstream, that's how we get to the social determinants of mental health. And so there's a number of social determinants of mental health that really drive the creation of a risk factor. They include things like adverse early life experiences and discrimination and low education and unemployment and poor access to healthcare and food insecurity and adverse features of the built environment and climate change. So all of these many things are the social determinants of health. They are what Link and Phelan call the fundamental causes of disease, and what Jeffrey Rose and Sir Michael Marmot call the causes of the causes, the thing that leads to and sets the context for the development of the risk factor, which then leads to the disease. So those are the social determinants. And the thought was, if you intervene at the level of the social determinant, you're good, because at that point, then you can prevent the thing from happening. As I've done more of this work, I've started to understand that if you're intervening at the level of the social determinant, you're still intervening too late, right? Because there is context that has been set. There are causes of causes of causes that have come even before the development of the social determinant of health. And what is that thing that's underlying even the development of the social determinants of health? That's actually social injustice. And so you see it here in this figure as unfair and unjust distribution of opportunity. And the thing that's really driving unfair and unjust distribution of opportunity are social norms, our beliefs about people, who we value in society, who we do not value in society, who's worthy of advantage and who's not worthy of advantage. And then public policies, the laws that we pass that reflect that belief system. So the ideas about who is worthy leads us to a number as a society, us passing a number of policies, creating a number of laws, and those laws interact with our values and our beliefs about people, our mindsets about people, to create unfair and unjust opportunity, which then leads to the social determinants of mental health, which then leads to the development of the risk factor, which then leads to the development of the disease. Okay, we should use an example. So let's think about, for example, crack cocaine. And so if we think about crack cocaine, what are our social norms about people who use crack cocaine? I think we have lots because the media is here to help us out, but most of the time we think we tend to associate the drug with Black people. And oftentimes these are not positive images that we have when we associate this drug. We think about Black people. If they are Black men who we associate with crack cocaine, we think that they're dangerous, violent criminals. If they are Black women, we tend to think that they're terrible mothers who don't care about their children. These are the things that society has told us, and these are the social norms that we have towards this population. Based on those social norms, we have created policies that reflect those values. So one of them is the Anti-Drug Abuse Act that was passed in 1986. This was the act that created a 100-to-1 jail sentencing disparity between crack cocaine and powder cocaine. And so what that jail sentencing disparity said is that if somebody was caught with 1 gram of crack in their possession, they would get the same jail sentence as somebody who had 100 grams of powder cocaine in their possession. So the policy was set up based on our values about who uses particular drugs and which drugs are good and which drugs are bad, that we created this policy. Keep in mind that we all know that crack cocaine and powder cocaine are the same chemical compound, but we also have an association with the idea that Black people are more commonly associated with the drug of crack cocaine, and white people are more commonly associated with the drug of powder cocaine. And because of those associations, the laws reflect those values. The laws we pass, like the Anti-Drug Abuse Act, reflect those values. One thing we can say is that over time, people recognize that this was a deeply concerning law that led to mass incarceration, that led to lots of problems in our society, lots of structural racism issues. And so there was a big push to eliminate this jail sentencing disparity. And the best that could be accomplished was in 2010, where the disparities were reduced from 100 to 1 to 18 to 1. There is still talk now about maybe we can reduce it and remove the sentencing disparity, but no one has really come to a place where that law has been able to effectively be passed, even though it's been brought before Congress multiple times. The other thing that we talk about when we think about crack cocaine is we think about how we associate crack cocaine with criminality. We associate it with incarceration. And one of the things that Ernest Drucker said in A Plague of Prisons was that the fundamental clinical accountability of drug treatment professionals to individual patients has been subordinated to the goals of the criminal justice system. I want us to think about that in contrast to how we think about opioids and how we think about opioid use, the opioid use epidemic, and what are our social norms around people who use opioids. What do we think about mothers who use opioids? We do not have the same ideas about what type of people they are. We don't have the same association with criminality that we have with this particular drug. And as a result, the laws and the policies that we've passed around how to deal with the opioid use epidemic is very, very different from how we approach the crack use epidemic. And so it is what we end up seeing is that those social norms and those public policies lead to unfair and unjust distribution of opportunity. And then they lead to a number of social determinants. So with crack cocaine, for example, when someone is incarcerated, because of many of our policies that we have when they get out of jail, it's highly unlikely that they will be able to have a job because they have to check that they have a felony, and that prevents them from getting hired. It's very difficult for them to get housing. Most public housing says that you can't have been arrested, and so many people can't return to their families when they have been incarcerated. That, of course, not being able to have a job affects poverty. It also affects access to healthcare. So there are a number of social determinants that are directly impacted by incarceration. It's not only that the individual determinant, it affects the individual, though it also has intergenerational effects, because we know that one of the adverse early childhood experiences is having a parent who's incarcerated. So that trauma then extends to children and generationally. So all of those social determinants come from this one policy that has really led to extreme unfair and unjust distribution of opportunity. So a couple of other concepts that we should really discuss, a couple of principles associated with social injustice, and we kind of highlighted some of them already. One of them is this idea of essentialism. This is the concept where people believe that there are distinct, unchanging, and natural characteristics that define social groups and facilitate their categorization. So we think very easily that we can put people into boxes, and we're taught this in our medical education. We're taught to categorize people, to make quick decisions about people based on certain aspects of their identity, which is really problematic because people, especially around issues related to race, ethnicity, gender, and sexuality, do not fit easily into these categories that we have, these artificial categories that we have created. Erasure of context is when we fail to consider the socio-historical context when we seek to understand the etiology of inequities. Of course, when we talked about Cartwright, I think that's a perfect example of someone not understanding the context of a situation. But we thought we can see this over and over again historically. One of the best examples of this is thinking about the protest psychosis and how Black people who were fighting for civil rights in the 60s were associated with psychotic behaviors, and the rise in schizophrenia diagnoses in Black men in particular is directly related to not understanding the context of trying to fight for civil rights and liberties. Biological determinism is the false belief that racial groups are biologically and genetically different. I have to always stop and pause around biological determinism, because most people, while in concept understand that biological determinism is wrong, do not really grasp this in practice. And a perfect example, of course, is that study, the 2016 Hoffman study, that asked a bunch of medical students and residents certain things about different populations, and a significant number of medical students believed biologically deterministic theories like Black people have thicker skin than white people, Black people have fewer nerve endings than white people. This is in modern day society, and this is being taught in our educational processes today. Cultural determinism is something a little bit different, but also the same, and that is the false belief that differences in racial group are primarily the result of cultural factors. And so this is when we say that the differences in health outcomes that we see have to do with the idea that this particular population has a completely different dietary habits, that Latinx population has higher rates of diabetes because they eat more tortillas, and without understanding any context or any understanding of the inequitable drivers that lead to these differences that have very little to do with diet. So we tend to put a lot on culture, and then we tend to kind of rank cultures and decide that certain cultures are making bad choices, bad decisions about what they do, and those bad decisions are leading to these differences in outcomes. So biological and cultural determinism are really cousins in kind of thought processes that we have to do away with. A couple of other concepts. These are the 5 faces of oppression. This is work by Iris Marion Young, where she talked about all of the ways that people can be oppressed. Of course, exploitation is the unequal exchange of one group's labor and energies for another group's advantage or advancement. Clearly, we see exploitation in many aspects of society, slavery, human trafficking, but even treatment of migrant farm workers or people that work in warehouses in modern day. These are all examples of exploitation of laborers. Cultural imperialism is when we establish the ruling class culture as the norm, and we other all those groups that are not part of the dominant culture. I use the example often of when we think about reference groups in our statistical analysis, when we think about odds ratios. And the fact that whenever I have looked at any study, and we're looking at odds ratios as it relates to race, never have I ever seen the reference group be anything other than white. And this doesn't matter how many people are in the study, it doesn't matter the numbers. We just kind of automatically revert to this idea that there's kind of a standard, and then anybody else that's kind of operating outside of that standard is abnormal. Powerlessness is when oppressed groups lack power or are blocked from routes to gaining power. Of course, I think the best example of powerlessness now is efforts to suppress voting, which is a way to keep people from getting getting power or gaining power in our society. Marginalization is when we expel specific groups from meaningful participation in society. We've talked about this with mass incarceration, but you also see this historically in the treatment of the Chinese Exclusion Act or the treatment of Japanese internment. There are very many examples historically of how we've expelled treatment of indigenous populations in this country. Violence is threats and experiences of physical and structural violence. I think that one kind of speaks to for itself, but I will just say that structural violence is when harm is done from a group that is in power to a group that has less power. So it does not have to be violence in a physical form, but it just has to be harm that is done. Okay, a couple more definitions, and then I promise I'll be done with the definitions. So structural racism, of course, is defined as a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequity. This system identifies dimensions of our history and culture that have allowed privileges associated with whiteness and disadvantages associated with color to endure and adapt over time. It is not something that a few people or institutions choose to practice. Instead, it's a feature of the social, economic, and political systems in which we all exist, and it does not require the actions or the intentions of others. Meaning that if we got rid of all of the interpersonal discrimination that exists in society today, the one-on-one interactions that we have that are discriminatory, we would still see racial and ethnic inequities in our society due to the persistence of structural racism, due to the way it has been baked into the very fabric of our society. So a couple of examples. We've already talked about crack cocaine, so the war on drugs, I think, is pretty heavily covered. Residential segregation, I'm not going to spend too much time talking about, but we know that this is how the process of redlining led to certain communities being invested in and given resources, and certain communities, particularly communities of color, being divested in and having resources taken away. The lasting impact on mental health has to do with the fact that in that divestment process, many mental health clinics were no longer available to those communities. So you started seeing whole communities not being able to access mental health services or health services because those communities no longer had health clinics in their neighborhoods. And you can look at almost any academic medical center and where they're practicing and see the effects of residential segregation. You can see that the clinics, including the satellite clinics, are never located in the sections of a city or a town that have been redlined or have been specifically targeted by these policies. Another interesting thing about residential segregation is it relates to COVID-19 vaccination. And a recent study found that in almost 69 different counties in the United States, there were communities in which Black and Latinx people lived in neighborhoods in which they had to travel greater than 1 mile I think I have this data. No, I don't have this data. That they had to travel greater than 1 mile to get to the closest vaccination site. Compared to white people. So an excess risk of having to travel farther to get to a COVID vaccination site. So we're back to thinking about how that is a residential segregation example, but also, again, we spend a lot of time when thinking about who's getting vaccinated for COVID. We spend a lot of time thinking, oh, well, these particular populations, there's hesitancy. People are not wanting to get these vaccinations, and yet we haven't considered the structural barriers that are preventing vaccinations in the first place. Immigration policy is another example. I'm not going to spend too much time talking about that, but just the idea that we've created specific laws that exclude certain countries, whole countries, and people from those countries from coming into this country. And then we created quotas so that people who have certain serious mental health problems or substance use disorders cannot come into the country as immigrants. And then we look at these things like the healthy immigrant effect, and we say, oh, this particular population must have something in their cultural background where they're doing, making better choices, making healthier choices. But we're not thinking about how our policies have specifically screened those people out of the pool, and that in every other country, you still see the same incidence of these conditions. The Social Security Act of 1935 was that act that created retirement benefits for older adults. There was concern about the idea that older adults would, when they retired, they did not have financial security. There was a lot of anxiety around how to retire and maintain some type of wealth and being able to pass wealth on to children and grandchildren. So this act was wonderful in that it created an ability for you to work throughout your adult life and then pay into the system, and then you could get retirement benefits as a result. Of course, the Social Security Act was a great law, but the structural racism aspect is that in order for that policy to be passed, it required the Southern senators that voted required that they exclude domestic and agricultural workers from being able to participate in the Social Security Act. In that time, back then, the majority of domestic and agricultural workers were Black people. And so they could not participate in the Social Security Act. They worked their whole lives and then they did not get that retirement benefit. They did not see the ability to pass that wealth on to their children or to retire at a certain age. So you start to see this huge widening of the wealth gap that occurred as a result of the between Blacks and whites as a result of the Social Security Act. And then briefly about mental health care. This is data from SAMSA in 2018 that showed that 69% of Black adults and 67% of Latinx adults with any mental illness received no treatment whatsoever. 42% of Black adults and 44% of Latinx adults with serious mental illness received no treatment whatsoever. 89% of Latinx adults with substance use disorders and 88% of Black adults with substance use disorders also reported not receiving any treatment whatsoever for these conditions. So I want to stop and pause and ask the question really quickly, what's driving these huge numbers? Again, I think if we take a health disparities approach, we can think of a lot of things that we typically think of. We say, oh, Black and Latinx populations, they have so much stigma. They don't want to access mental health services because culturally, it's just not something that they do. We may say that these particular populations have less insight. They don't realize that they have a problem. So they're less likely to seek help because they don't realize that there's a problem in the first place. I think we traditionally go down this route. But when asked, cost was considered the most commonly cited reason that people did not seek care. It was twice as often as minimization of symptoms and nearly 5 times as often as stigma. And so, again, this is a structural reason for why people aren't accessing services that we've designed an inequitable mental health system that makes it impossible for people to access services. So it has very little to do with the cultural beliefs and values of the population. It has very little to do with a lack of insight or any number of things that we've tended to say is driving the cause. It's the structural construction of our healthcare system that's making it hard for people to access services. So in the time that we have left, I'm gonna try and offer up some solutions, but I will remind, as I've been saying all day, I really don't have the solutions. So I will be open for discussion as we move on. So we're in the state of inequality right now. That's when we have unequal access to opportunities. And some people think that the answer, the way forward, is that we have to reach this state of equality. Equality is when we evenly distribute tools and assistance. When we think about equality, we're focused most on fairness. We're saying, and this has been something that we've thought about when we've done diversity, equity, and inclusion initiatives from the beginning of time. We say, whatever we do, we have to be fair. We have to make sure if we do something for one population, we do the same thing for another population. And you can see based on this figure, that really actually doesn't get us to where we need to go. So one of the places we need to go is we have to think about equity. And that's when you customize the tools and that really are identifying and addressing the inequality for that specific population. So you give that specific population the intervention that they need in order to be successful. So it's not so much focused on fairness, but about giving people the actual intervention that they need. But that's actually not enough. It's a starting place, and we have to think about equity, but we also have to think about justice. And justice is when we fix the system to offer equal access to both tools and opportunities. And so when we think about what the solutions are, I think we have to focus in on what are the justice level solutions that we can try to address. And so how we might be able to do that are a number of things that include kind of individual level work as well as more structural level work that we all need to do. So the first is education and self-reflection. And I just have to stop and say this is not stuff that we are taught. Very few of us were taught these things. I encounter these days a lot of medical students that did a lot of work where they learned critical race theory and other things in their undergraduate education, and they have incredible expertise in this area, but they are not the standard person who's working their way through medical school or nursing school or social work school and ends up becoming mental health providers. Some of them do, and they do incredible work, but they are not the majority. And so for us in the majority, we actually have to commit to learning this work. And we have to make that commitment. It's not easy because we don't have time. We're all very busy. But this is really important, and so we have to commit to this. What I asked my residents to do is tell me which of these books that they're going to commit to read in the next few months. These are books that really start the conversation. There's a number of scholars and great scholarship happening, but what's interesting about this is that even though there's incredible scholarship in this space, it's also done in highly readable ways, in ways that it's easily accessible, that you can get to this material and you can learn this material pretty effectively. But I will also say that we are very, very busy people. And so those books are also very dense. And so this is like the cheat sheet. This is for people who really just have no time whatsoever. These are podcasts that really can give you a very brief introduction to the topics. Some of them are really deep introductions. And these podcasts are very easily listened to on your commute to and from work. There are a couple of books in here that I've listed just because they are books that are easier to read. They're not as, they don't require the same level of intellectual commitment as the books on the previous page. And then documentaries such as I Am Not Your Negro that are also really powerful. Much of the work around education and self-reflection relates to cultural humility. Cultural humility has three tenets. One is committing to a lifelong process of self-evaluation and self-critique. And I think that's the most important initial tenet. This is not work that we take a course. You know, when we think about cultural competence, we think we take a course and then we're competent. This is not work where we can just take a course and be done and we did what we came to do. We actually have to commit to doing this work for the rest of our lives, which I think is painful for some people to try to come to terms with, but this is the work that we have to do. And we have to be willing to look at ourselves critically and say, what have we done well in this space? Where are the areas where I have blind spots? Where are the areas that I need to do more work? I was actually just having this conversation the other day because more than once now I've caught myself not thinking first about people with disabilities. And I thought I've spent enough time now where I've been doing this work, and I obviously have much more work to do around thinking about disabilities, because even as I have recognized that these things are important, I keep not automatically thinking my leaving this out in my thought process is work that I need to do. So that's self-evaluation and self-critique work that is hard, but necessary. We have to desire to fix power imbalances between our providers and our clients. That's looking at all of our interactions that are happening in our work settings and recognizing when we see power imbalances that don't need to be there and getting rid of them. And we have to develop community partnerships to advocate within the larger organizations in which we participate. And that is work in cultural humility, but there's also work to be done in structural competence. And that structural competence is defined by Helena Hansen and Jonathan Metzl as the trained ability to discern how a host of issues defined as symptoms and clinical problems and attitudes and diseases are influenced by upstream social determinants of health. So we have to exercise these two muscles, and we almost need to think of it as structural humility. So the idea that we're learning when we see the patient in front of us, we're thinking about all of those cultural humility factors, but we're also thinking, what are the structural factors that have played a role in your life and are impacting how you present in this room? So we have to be thinking all about like what's going on individually, but we also have to think about how that human interacts structurally with the rest of the world. And then I mentioned, of course, that it is about social norms and public policies. And so if we're going to promote social norms of inclusion and equity and respect, that involves us all becoming officers of enforcement, making sure that we are creating and designing communities and spaces where social norms of inclusion and equity are enforced. I want to take a second to point out that sometimes in the space of this idea of enforcing social norms, people get caught up in this idea of cancel culture and the idea that if you say the wrong thing or you do the wrong thing, you will be canceled. And I will say that that is not what is meant by enforcing social norms. When we're talking about enforcing social norms, we're really talking about helping to educate those people who, when they aren't understanding a certain concept, being very gentle and very open about calling that person in and giving them feedback and educating them within the community. So it's very like generous work. It's very loving and very generous work to help bring people along. And I would say that education to change social norms is critical. that is where we should strive to go. But there is a very small percentage of the population that no amount of education is going to help them because they possess beliefs that cannot be changed. And for those people, for that small percentage of the population, we can legislate. So we can use the policies that already exist in our society to prevent those people from having power and to prevent those people from doing harm. We need to observe and challenge our own implicit biases. We have to look at the ways in which we automatically think about certain populations and groups, and we need to challenge ourselves on that work. What's great about this is that we all have implicit bias. It's a neurobiological process. The more you develop the skill of recognizing your implicit bias, the harder the work becomes, because you start to feel very negative about the fact that your biases don't reflect your values. And so this is hard work, but it also involves giving yourself some grace and letting yourself off the hook sometimes for the fact that our biases are what they are, and we'll always be working on them. And again, I mentioned this before, but we have to evaluate and break down unnecessary hierarchies. That involves looking in all aspects of our settings, our work settings, our department, our environment that we're in, and saying, which are the hierarchies that we have in place that are necessary? Like in a surgical suite, for example, there are hierarchies that are necessary. Which are the hierarchies that we have in place for no particularly good reason except to allow people in power to feel powerful? And for those hierarchies, we need to think about breaking those down and removing them. If we're going to advocate for equitable public policies, I think that gets to this concept that all policies are health policies. We need to take action beyond the walls of our clinics, our hospitals, our treatment centers. We need to advocate for policies that address social determinants of mental health. We need to spend time with our elected officials and promote equitable representation. And we must form cross-sector collaborations and community coalitions. So I will say that in wrapping up, that there are a couple things we need to think about. The first is that political stances and policy interventions are required, because to remain apolitical or neutral is in fact a political stance, because you are tacitly accepting the status quo. And as I hope I've laid out today, the status quo is not acceptable. And I will leave with two final comments and two final thoughts. One is the idea that we all have to work on speaking up and taking a stand. And so this is a quote by Audre Lorde, who said, "When we speak, we are afraid our words will not be heard nor welcomed, but when we are silent, we are still afraid, so it is better to speak." And finally, to end, we've seen, I think we've been on a tumultuous few years, and particularly the last year with the pandemic and with the change in racial equity. And I think that a lot of progress has been made, and we can feel really positive about the progress we've made in the society. Progress is, of course, made through the passage of legislation, through court rulings, through other formal mechanisms that aim to promote racial equality. But one of the things I think it's really important to understand that always with progress, always comes retrenchment. And retrenchment refers to the ways in which progress is very often challenged, neutralized, or undermined in key policy arenas. And so with every movement towards progress, we have to be prepared for the retrenchment that comes. If we're not prepared, it's very easy to get overwhelmed, to despair, to be really upset. And so I want to end on a somewhat hopeful note, and hopefully with an antidote to that retrenchment and despair. And that's with the words of Congressperson John Lewis. He said, "Do not get lost in the sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, a week, a month, or a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble." Thank you.
We're going to have questions and answers, and Art's going to lead us through that. But I just want to thank Ruth again. That was a wonderful talk. It was obviously very educational. It was very pragmatic, I think, from the standpoint of specific things that we can think about doing. And even though it's obviously a very tough topic, I found it very inspirational, and appreciate your energy with this, and us leading the field and helping us with it too. So thank you, Ruth.
Thank you.
And Art, do you want to go ahead with?
Yes, certainly. So we invite folks who are here live with us to come up to one of the mics on either side if you have a question. So come on up. Don't be shy. We've covered a lot of wonderful territory here. I'm sure there are plenty of questions and comments. I'll get us started with a question from our at-home audience. So this is from one of our residents, and I'd like to acknowledge we've got resident and other trainee presence here and at home. So great to see that turnout. So the question is there an evidence base for which implicit bias trainings are more or less effective?
That is a great question. The evidence is actually pretty poor, unfortunately, around implicit bias trainings. It is, and I think it relates to, again, the complexity of the issue that we're talking about, which is that structural level changes are unfortunately never gonna be uprooted through implicit bias, through just addressing implicit bias. And so the data reflects that. I think that most implicit bias training may lead to people developing a greater awareness, and then can lead some people to change their individual actions. But most of the implicit bias training data does not show that collectively, after participating in implicit bias training, a significant number of people have made significant changes. One of the things that implicit bias training does show, which I think is really important, is that people of color actually tend to have less negative implicit bias towards patients of color. And that is data that has kind of been consistent in the implicit bias data training. So yes, it is possible. I think it is possible for white people to participate in implicit bias training and move their thinking. But more effectively, I think it would be to try and make sure there are more people in the workforce who don't have the same level of negative implicit bias towards certain populations. So the implicit bias training is really telling us, I think if we're going to learn something from it, it's telling us that diversifying the workforce is actually really important work that we should be focusing
on. So I really appreciate your point on, I guess it was related to cultural humility and the need to self-reflect, try to identify blind spots. Well, the tricky part about blind spots is
you don't know you have them. Right?
And so, your suggestion, I think, of using resources that are available, books, podcasts, in order to stimulate discussion, to start to think about things that were not maybe occurring to you sort of intrinsically, is an excellent idea. And I think one thing we're trying to work through as a department is how do we organize spaces, venues to have these conversations? Because I think what we see a lot is people don't feel like they have time, or it's a very self-selected group, or you've probably traveled a lot of places, had a lot of these conversations. How have you seen this done effectively in a way that invites broad participation?
Yeah, that's a great question. Thank you. And we talked a little bit about this earlier. The challenges are, there are a number of challenges, but the biggest one around the work is that, this is actually like work that white people have to do, right? So it's less work for people of color. And honestly, people of color and people like myself, we can't actually lead this work, nor would I want to, so the work involves white people leading and pushing the conversation, and then white people helping to bring their colleagues along. So there are some white people who've spent a lot of time thinking about this stuff. And again, it's a lifelong process, but they've done that work and they've spent a lot of time reading these books and thinking about it and self-reflecting. And so we talked about how if successful places have created groups, created safe spaces for white people who are not as far along. And I say, by the way, when I say white people, I'm actually meaning lots of people. I'm not just talking about our poor definitions for white people aside, because we don't have good definitions, but I'm actually talking about people that fall into the category that they are not in the underrepresented minoritized group. And that can be many people. And it could be, I could be talking about Asian people, and I'm saying white people, but I don't mean white people. But I think that work needs to be done in a way where it is safe for people who are not as far along to be able to try out some of the complicated concepts and be okay with saying certain things that may or may not would be extremely hurtful if said directly to a Black person or to a minoritized group. And so that's like the development of safe spaces, I think, is particularly something that can move people forward. And so it's tricky though, because we're saying, okay, we're creating like white people spaces that are safe for them to particularly do this work. So a way that this has been, I think, successful in other places is to kind of tie this to book clubs. And the idea that any number of those books, okay, we're going to get together and we're going to talk about these concepts, and we're going to talk about it in a way that if you don't say the right thing, or if you don't say it in a reasonable way, you're not going to be penalized for that as you're trying to think through and do this work. And again, I don't think it's ideal for people of color who are directly impacted by the harms that can be done when people are trying to learn how to say these things properly. I don't think it's ideal for them to be in those settings. I think that creates kind of harm. So that's the work. And how do we move people along? Again, there are some people that will definitely want to do this work, and we're all very busy, but still will make time. There are other people that probably need the help and they don't have the interest. Where I think a lot of power can be had in this space, and I'll put Dr. Kalin on the spot, is that leaders, particularly white male leaders who are pushing the movement can be very powerful in this space. And I've actually seen this play out more effectively. You can, if you have a leader who is specifically demonstrating by example that can help move people along. So I think it's work that we have to acknowledge, that it's work that white people need to do, and that they need to be given kind of time and space to do it, and in a way that they can feel safe in doing that work. Great question. Okay.
Yeah. I appreciate your comment directed at me, and I will do that, and will continue to do that. I'm interested in the implicit bias concept in relation to the self-work.
Yeah.
Is that and for some people, is that an entree to do the self-work? Your comments about the evidence doesn't really support the implicit bias training as being particularly effective.
Yeah.
So how do you think about the two of them, I guess, and in a practical way, how can we put those together, for example, in our department?
Thanks for that question. So the implicit, I actually think of the way I think of implicit bias, I do think of it as an entree into the work. So it's a way to introduce people who haven't thought about these things to these concepts. So, if you do an implicit association test and you find out, oh my gosh, I have all this bias, that's like a starting place. But it's a very early starting place. And then the work that comes after that, I think, is most critical. So it's one method by which to help people understand that these concepts are real. And it can be a starting place for a lot more discussion about, okay, how then do we move forward and try to do better? I don't think, though, I think what's been problematic in thinking about implicit bias training is that we've spent a lot of time trying to teach people to not be biased. And that, I think, is not helpful. I think that sends us down a wrong path. And I again hear all these really smart, talented people say, oh, I used to have a bias against this population, and then I did my work and I no longer have that bias, because what they're saying is they did an implicit association test and found a negative bias. And then they did another implicit association test 6 months later, and it was different. The outcome was different. And what we know about the implicit association test and that data is that there are many, many reasons why the outcomes are different, and they're different for many reasons all the time. And so people then think that their job is to eliminate their negative bias. But I actually don't think that that's the work, because I think we all have negative biases. It's being aware enough of our biases to make sure that those things don't come into play with the decisions and the interactions that we have with people. So it's not necessarily trying to get rid of the bias. It's much more about how aware am I so that I don't say something because of my bias, or I don't make a decision about something because of my bias. So it's a very early start, but then the work that has to be done, I think, is much less focused on actual implicit bias training. And I think where we run into problems is we're trying to do trainings to teach people how not to have bias, and that, I don't think that that's an effective strategy.
The audience.
Thank you. First, I wanted to say thank you. I thought this was a wonderful presentation. So I'm the executive director of a nonprofit here in town. We work on employment supports for folks with serious and persistent mental illness. So I was really interested in what you were saying about social determinants of health, and then kind of going upstream and talking about this idea of who is worthy. So we talk a lot about stigma and sharing stories of people with lived experience. And I'm just curious how you connect stigma to who is worthy, and if you have other ideas on how to have conversations with the general public about worthiness.
Yeah. Oh, those are great questions. So I think that stigma is directly tied in with oppression. So like all of this is all tied together. So we have decided that people with serious mental illness are not worthy of certain things in society, and we have made decisions and policy decisions. We've excluded them. So we have oppressed people with serious mental illness, and those 5 faces of oppressions I've talked about. These are all things that have been done to people with serious mental illness, especially the powerlessness. Right? We have removed people with serious mental illness's ability to advocate for themselves, to make decisions for themselves, and to organize in any sort of effective way to kind of promote their own needs. Historically, what we saw in like the late 80s with the community mental health movement and the rise of like peer support and all of these things was like an attempt, a very positive attempt to try to move in a direction in which power was kind of taken back. But I don't think it was like a complete process. And I think, the struggle continues. So the question of trying to think about how to kind of relate these concepts and how to think about moving away from stigma as it relates to these issues, I feel like we have to consider drawing the connection more effectively between oppression, injustice, and how that has been couched in this language of stigma. And I don't think it has been, I think that's like one piece, but like the underlying issue is kind of the systematic oppression of certain populations. I realize I'm not answering your question, but I somehow I feel like the last thing I think I'll say about this is that one of the books that I listed was The Sum of Us by Heather McGhee. And what she talks about is how we think about these issues as like zero-sum game issues. The idea that like if you give benefits to one particular group, that will harm other groups. And I think that that's in some ways the ways we've thought about serious mental illness, like that we have not necessarily equated the struggle against oppression. We have kind of separated out. So one of the things she talks about is how the movement of minimum wage, addressing minimum wage and moving to a living wage really kind of picked up in this country when really diverse groups came together to effectively, collectively argue for change. And I feel like that is the work that we need to do around people with serious mental illness. I think that we, even the groups that have been oppressed, that have been actively fighting against oppression, have excluded this particular group. And I think that bringing all of these groups collectively together would be one way to be more effective in this space.
We have lots of questions.
Wonderful.
First of all, lots of statements of gratitude from our virtual audience for this wonderful presentation. I have two related questions, so I'll just ask them together. One is, are there specific states, cities, and so on that have made the most progress related to social equity or racial equity in mental health care? What innovative models should be implemented or considered? And then a similar question, but at the university level, which is do you know of any large, predominantly white institutions that have made some headway with regard to challenging existing university structures that perpetuate inequity and contribute to mental health challenges?
These are great questions. I am very much aware of institutions where a small group of committed people are making progress in those institutions. And I think that's happening consistently across the board. And I think they're too numerous to count, but the challenges are, and they're making great progress. The challenges are that they are bumping up against the structurally racist policies that exist in kind of all of our systems and make it difficult to really see that movement really take hold. It's not a system that relates to racial justice, but one that I think has done it inadvertently has addressed racial justice issues that I've heard about, that I was relatively impressed with, was Nationwide Children's Hospital in, I believe, Cleveland. Is it Cleveland, Ohio? So they actually did some really impressive work on addressing the social determinants of health and mental health by partnering kind of across the community to address inequity across all social determinants. So for instance, they created like educational pipeline programs where if you grow up in the community and you graduate from high school, you're automatically given a job somewhere in that health system. You know, like there are these like structured pathways that they did by working with politicians and business people and you know, all of the leadership of the hospital and the community. By forming these incredible community partnerships, they created many kind of direct programs that address social determinants and are really about this concept of anchor institution mission work, where the institution is the driver of economic improvement for that community. And so there are examples like that. From a racial justice perspective, I was talking earlier about white coats for Black lives, which is, and this isn't directly related to mental health, but it has impacts on mental health. But this is a student-run organization that has very much used kind of this collective organizing movement to be able to have like the Black Lives Matter movement, have like a diffuse leadership where no one is kind of directly accountable. But yet they have created something called the Racial Justice Report Card that they use for health systems, and academic health systems have used this as a tool to measure their outcomes in terms of racial equity across the health system. And so each institution that completes the Racial Justice Report Card gets a number of scores, a letter grades across a variety of metrics, including how diverse is your faculty, how do you care for patients of underserved backgrounds, like how does your institution do that? And you get a letter grade for each of these things. Even basic things like, do the photos of people on your walls reflect diversity, or are they mostly older white men? Like this is built into that metric system. And this has been, I think, at least at my institution, I've seen it be an incredible driver for change. Once the school got its grades from the White Coats for Black Lives students, there was an action plan developed around how to address the grades that needed to be improved, and active work is happening in that space right now.
Dr. Shim, thank you. You've been so generous with your time. I'm going to ask one more question here and then we'll close out.
I think there was a question over here too.
Oh, I'm sorry.
So two more questions. Two more questions.
One I want to close with.
Okay.
I always get kind of nervous asking questions in this kind of setting. And it's something that I always struggle with the words to talk about, like basically classism, its impact on mental health and implicit bias. I've worked most of my career in the drug and alcohol field in a nonprofit mental health center. And I noticed our staff, most of them came from a middle class background. Most of the people we serve work in poor and under. And I saw a lot of what I saw was bias, but it's always hard to put into words. So I'd really like to hear your thoughts on classism, how it connects to what you're talking about. And thank you.
Thanks for that question. I think it's critical. I think that class is critical to this discussion. And I would again refer us back to another one of the books that I had recommended, which is Caste by Isabel Wilkerson, which really talks about the structure of a caste system in the United States and how the caste system is broken down into white people, everybody else, and Black people in the society. And what you see there are that there is a caste system that also falls along class lines, but not so much. So when we think about caste and the intersection between class and caste, you see that there are poor white people who are, clearly are experiencing the extremely negative effects of a classist structure that we exist in today. But because of the racial inequities that have been built into our system, they have even at this class level in which they are discriminated against and they're treated poorly, they have still aligned themselves with the dominant caste. And by aligning themselves with the dominant caste, they still have managed to have something instead of nothing. So the intersection of caste and race is extremely complex. It's something that I think that we have to be very mindful of. And again, it's a way in which people, I think, have been successfully able to divide communities that would have much more shared interests in advocating for improvement, but it's been a way to kind of keep certain groups apart from each other. So there's a lot of really shared interests that poor white working class people have with poor Black working class people. And yet those two communities are extremely divided. And so part of it is understanding like how the caste structure has created that division, and then how do we kind of bring those groups back together? Because the more we have power within those numbers, the more effective we can affect change around the oppression of people that are poor in our society. And then the last thing I'm going to just say about that is that there was the United Nations had a special rapporteur who did an assessment of the United States around the ways that we look at poverty in the society. And his ultimate recommendation or concepts were, we have a culture in which we punish poor people and blame poor people for their poverty in ways that doesn't happen in other countries. And this idea that poor people are poor because they did something to earn their poverty. And then we've created a system, a safety net system that really does not do anything to help support those that are poor. So again, I think we have some really, and I believe that the reason that we've become so punishing of poor people relates to this caste system and the idea of who should be at the bottom in our society, and that we shouldn't help those people that we've decided are at the bottom of our society. So I would just end by saying we have a lot of work to do. We have a lot of work to do in soul searching as a society to do in this space.
Okay, we'll close with this one. Thank you so much for a truly inspirational talk on such an important topic. It's easy to feel hopeless when faced with the entrenched and self-reinforcing nature of structural racism. Can you talk about your personal practice of maintaining hope in this work?
Oh, that's a great question, and I can answer that very easily. It has to do with working with students and residents. And I think that I always feel like, and I tell people, I'm not doing this work for me. And I'm also like not expecting to make any sort of changes. But what I do notice when I work with residents and when I work with students is that they're so much further along in thinking about these things than I ever was at their stage, that I actually have pretty significant hope and confidence that they will make great headway in this space. And so that keeps me going, because it also means that my goal here isn't to like fix this stuff. My goal is just to give the residents and students the tools they need to be successful in solving these problems for us. Thank you.
Thank you. So just a reminder that you haven't seen the last of Dr. Shim. We have grand rounds tomorrow in the department. You're all invited to join us. The topic will be a little bit more focused on mental health and the impacts of racism, following along these topics. So please come tomorrow too, and we'll hear more from Ruth. Thank you again.
Thank you.
Yeah.
It really kind of